Okay, good morning, everyone, near and far. Thank you so much for coming, and thank you for the invitation for me to be here and to share some of my retrospective experience using the nanofibrillar collagen scaffold for lymphedema surgery. I have no disclosures. And the treatment of lymphedema remains very challenging, and for us, we use a multimodality approach to with the aim to return the limb to its normal volume and function. So as we know, physiologic procedures address the fluid excess component. The debulking procedure addressed the soft tissue component. However, both of these procedures does not address the increasingly non-functional lymphatic channels throughout the length of the limb that occurs as the disease progresses. And so to address this problem, we sought to assess the efficacy of incorporating a nanofibrillar collagen scaffold called BioBridge in combination with our surgeries to prolong treatment success. So BioBridge is an aligned nanofibrillar collagen scaffold that's made from highly purified type 1 bovine collagen. It's manufactured as a thread formed by aligned collagen fibrils. It's FDA approved for soft tissue reinforcement repair and has received EC certificate for lymphatic tissue repair in Europe. The large surface area and the interconnected cavities of the scaffold enable cell infiltration as well as local interstitial flow. And prior studies have shown that endothelial cell, when seated onto the scaffold, are more viable compared to non-aligned collagen scaffold by facilitating self-attachment, alignment, and migration. So in our previous animal model study, we found that the rats in the BioBridge treated group initially had an increase in volume after lymph node dissection and radiation, but then had complete resolution of the edema at 4 months. The prevention group never developed lymphedema and had maintained negative relative volume change over the 4 months follow-up period in the study. ICG fluoroscopy further showed restoration of lymph volume, lymph flow in the ipsilateral affected region towards the nearest nodal basin in the axilla, and then there are formation of new lymphatic channels that we see directed towards the contralateral groin in both the prevention and the treated groups. So how does the BioBridge work? In normal physiologic state, the lymph node secretes growth factors that create a gradient for migration of lymphatic endothelial cells. And the BioBridge helps to direct lymphangiogenosis by providing a multiluminal structure that promotes lymph flow via capillary effect, and hence guiding endothelial cells migration and lymphatic capillary network organization towards the lymph node flap and ultimately to the native lymph node basin. So based on previous reports that show that interstitial fluid channeling precedes and guides lymphangiogenosis, we hypothesized that the aligned multiluminal structure of the collagen scaffold BioBridge can direct lymphatic regeneration and improve outcomes in our physiologic procedures. So to this end, we have built on our previously reported algorithm using a combined liposuction and physiologic treatment to achieve normalization of lymph volume in patients with stage 2 to 3 lymphedema. So initial treatment is, for us, is dependent on the lymphedema stage and the makeup of the excess volume. So patients with excess tissue characteristic of stage 3 lymphedema, for example, would receive liposuction first, followed by physiologic surgeries to help restore flow. Those with mixed presentations are offered liposuction and physiologic surgery simultaneously. And those with mild to moderate pitting edema are candidates for physiologic procedure alone. All of our patients undergo lymphatic mapping prior to physiologic procedure to identify if there are any blocked distal superficial lymphatics. And those who do have blocked lymphatics are candidates for LVA with the addition of VLNT if they have history of recurrent cellitis. Those who don't have any blocked lymphatics seen on lymphatic mapping are offered VLNT. Our patients are then followed for up to a year to 2 years after surgery to allow them to reach homeostasis, at which point excess tissue is addressed with additional lymph-sparing liposuction, and excess fluids is addressed with placement of BioBridge to further augment their lymphatic drainage. So candidates for our patients are those who have had stage 1 to 3 lymphedema, who have been treated with physiologic procedures or liposuction, a combination of both, who had basically received suboptimal or unsatisfactory results and want to have a better outcome. All of our patients cannot have acute infections around the time of surgery, approximately 1 month. As I mentioned, all of our patients undergo preoperative lymphatic mapping with ICG fluorescent imaging to verify staging and to identify areas of intact lymphatics and area of dermal backflow. And when used in conjunction with VLNT, after lymphatic mapping is performed, surgery typically involves releasing any scar tissue as needed, and several BioBridge tracks are then created subcutaneously, and the scaffold is tunneled proximal and distal to the lymph node flap, such that they cross the areas of dermal backflow while linking the native lymphatics to the lymph node flap and to the existing lymph node basin, ultimately to create a network that tries to mirror physiologic lymph flow. So this is schematically shown for upper and lower extremity here. This video is a cartoon that kind of shows how the scaffold is placed. Basically, we use an introducer. It could be a trocar or a suture passer that is then tunneled subcutaneously through the tissue, and the scaffold is basically pulled through the subcutaneous tissue and is routed towards the lymph node flap. In this case, in the cartoon, is placed in the axilla. And then we also route the scaffold from the axilla to the supraclavicular lymph nodes. When used as an adjunct therapy with LVA, again, we do ICG lymphatic mapping preoperatively, and the BioBridge are placed, in this case, in proximity to the LVA or the intact lymphatics, and then they're tunneled subcutaneously proximally to the nearest nodal basin. Again, the idea is to bridge any area of dermal backflow. So in the upper extremity, we typically route the BioBridge to the ipsilateral and then contralateral supraclavicular lymph nodes. In the lower extremity, we route it to the ipsilateral and then contralateral groin lymph nodes. The goal is to reestablish unidirectional lymph flow from distal to proximal to the nearest functional nodal basins. These show some of our early results. So on the left is an intraoperative photo showing the location of the BioBridge insertion relative to the lymph node transfer. Preoperative ICG showed very significant diffuse dermal backflow and no presence of any linear lymphatics. Postoperatively at a year, we found that the degree of dermal backflow is much decreased, and there are now formation of several linear lymphatic channels. Another example, this is a patient with secondary lymphedema of her right arm who had, I did VLNT, and then subsequently 2 years later had BioBridge placed. Her preoperative mapping showed few lymphatic channels with residual dermal backflow, and postoperative BioBridge placement, we now see presence of new linear lymphatic channels in the proximity where the scaffold were placed with decreased dermal backflow. Radiographically, this is her preoperative lymphatic mapping. Again, showing that there were sparse lymph channels with dermal backflow in the upper arm. The lighting is not so great, so hopefully you can see. So not much activity in the arm despite VLNT. And her postoperative lymphatic mapping now shows new linear lymphatic channels that we can track towards the lymph node flap as well as draining to her axilla. And there's still some residual dermal backflow, but significantly less. So here we see some dynamic lymph flow. And draining to her axilla. So clinically, this patient initially had 19% excess volume in her right arm, which decreased to 8% after VLNT, and then to 1% at a year following BioBridge placement. Another similar patient who had left arm lymphedema with 37% excess volume, had VLNT with 10%, with a decrease to 10% at a year and a half. We placed the BioBridge scaffold and was able to reduce her volume further to 5% at 6 months follow-up. This patient had May-Thurner syndrome and chronic left leg lymphedema, who had VLNT to the groin and BioBridge placed in the left leg. His pre-op excess volume was 11%, which decreased to -4 at 14 months follow-up, and is still stable at negative excess volume at beyond 2 years post-op, and his LDEX is still normal. We were able to get lympho MRI for him post-operatively and compared to pre-op, and this showed evidence of new lymphatic channels where we placed the scaffold, starting from the calf region and all the way towards his groin to his lymph node flap. Our experience with the scaffold is similar actually in the LVA group as well. They also respond well. This patient had early stage 2 disease of her left leg and had 10% excess volume, had LVA done as well as subsequently BioBridge. I couldn't find her interim photo, but this is her most recent post-op photos at 19 months showing -2% excess volume. Another patient with early stage 2 lymphedema who had LVA and then had BioBridge 8 months later. Again, her volume was able to remain normal at 8 months follow-up after combined procedure. This is her pre-op lymphatic mapping after LVA prior to BioBridge placement, showing that there's some intact lymph flow, but the flow is slow, and there are a few functional lymphatic channels and some blocked vessels, as you can see here. And after, let me see, here it is. So this is her ICG mapping after BioBridge placement. And so now we see that there are new channels that are formed. The flow seems to be a little bit quicker. And the most exciting part is now that we see actually lymph flow directed towards the groin. There's still some residual dermal backflows. Okay. So we recently reported our retrospective outcome of the first 18 patients who had BioBridge placed in combination with physiologic procedure with or without liposuction, compared to our traditional control patients. And the initial ratio of excess volume was pretty equivalent in both groups, but we found that the treated group had significantly greater edema reduction compared to the control, with an average follow-up period of over 2 years. This just to show that even in the cohort who don't, the patients who don't respond well to physiologic procedure, so this is the volume excess before BioBridge place. So this is after physiologic procedure, and they respond not as well as to some of our other patients, and these are the patients who would like to have better outcome. And after BioBridge placement, we can see that they actually did better than the group who didn't have the BioBridge place and did well, based on just conservative physiologic procedure. Sub-analysis of the LVA and VLNT groups similarly showed statistical significant volume reduction in each of the group. The VLNT group did better than the LVA, and that's kind of expected based on the mechanism of how VLNT work by secreting growth factors, which can further stimulate lymphangiogenesis, resulting in better outcome. We also looked at their ICG lymphatic mapping and found that the treated group had more formation of lymphatic channels compared to before the BioBridge were placed, and also compared to the control group. So 4.5 versus 1.8. Again, the most exciting part for me was that we can see now some of these collectors reaching the axilla or the groin in 50% of the cases. And finally, I wanted to see if BioBridge can further improve and prolong outcome for patients who have large volume liposuction. We know that using the dry liposuction technique, we can really normalize the patient volume, but they're kind of tied to wearing really high compression garment for lifetime. So can we improve their outcomes such that they can wean down on their dependence on the compression garment? So we looked at the use of BioBridge in stage 2 to 3 patients who had more than 150 cc of liposuction, and the average for the upper extremity was 50, but was 500, and the average for the total volume removed for lower extremity was I think 1.8 liters. So these are large volume liposuction patients, and they previously had combination procedures which can really normalize their volume, which has been reported in the literature. But we found that the majority of these patients continue to maintain their volume at normal volume at an average of over a year during our follow-up. The result was consistent when stratified to the arms and the legs. They similarly did well. And the results were also similar when stratified based on the types of physiologic procedure, VLNT or VLNT in combination with LVA. These are some clinical examples. This is a patient with 24% excess on the left arm, and basically after VLNT and liposuction reduced to 3%, and after BioBridge placement remained stable at 21 months total follow-up. This is a young lady who has a primary lymphedema of her left lower extremity and had physiologic procedure plus liposuction. So I did an LVA plus VLNT to the groin, and she also had some liposuction to debulk the fibrosis in her thigh. We brought her down to 4% excess volume, and with the scaffold placement remained at -2 at a year follow-up. This is also another primary lymphedema who also has capillary malformation in her left leg, similarly treated with combination therapy, and basically was able to keep her volume stable at 13 months follow-up after triple therapy. So when we compared these BioBridge treated patients to historical controls, we found that triple therapy really maximizes volume reduction in the appropriate patients and can sustain outcome close to 2 years follow-up. We have some early preliminary immunohistopathology results show evidence of lymphangiogenesis in the treated groups. They do have normal looking lymphatic channels where the BioBridge were placed, kind of consistent with what we see on imaging, but the number of lymphatics seen in the vicinity is still less compared to normal tissue. So in summary, we found that BioBridge is an effective adjunct therapy when combined with physiologic procedures in the treatment of lymphedema, and in early stage lymphedema, it can help normalize the lymph volume. It can be used in patients who have large volume liposuction in combination with other procedures. And our results shows that it helps to stabilize the outcome long term. We now have some clinical evidence of radiographic evidence on ICG as well as MR showing increased lymphatic drainage as well as new lymphatic formation, and some early evidence on immunohistopathology of new vessels formation in the treated group. So in our practice, combination therapy using physiologic as well as reductive and scaffolds, particularly in advanced stage lymphedema, we found that the combination approach can really help maintain long-term results because they address the key components of late-stage lymphedema, which is improving drainage lymph flow as well as removing the excess fibrosis that is there and then guiding the formation of new lymphatic channels. So currently, Dr. Chang, David Chang, is leading the clinical trial on prospective use of the BioBridge with lymph node transfer, and we're partnering with him as well. Thank you.